Today we are covering burn injuries, focusing on the concepts you must know for the NCLEX. The exam will test your ability to quickly assess the severity of a burn and initiate the most critical interventions. Let's start with calculating the total body surface area, or TBSA, involved in a burn. For adult patients, the NCLEX expects you to use the rule of nines. This method divides the body into sections that represent 9% or multiples of 9% of the total surface area. For example, the entire head and neck are 9%. The front of the torso is 18%, and the back is another 18%. Each full arm is 9%, and each full leg is 18%. An exam question might describe a patient with burns on their entire back and the front of their right arm. You would calculate this as 18% for the back plus 4.5% for the front of the arm, totaling 22.5% TBSA. A common exam trap is to describe a burn on only the anterior or posterior portion of an extremity, so you must have the typical 9 or 18% value. While the Lund-Browder chart is more accurate for children, for the NCLEX, you should primarily associate the rule of nines with adult burn calculations. Once you have the TBSA, your next step is fluid resuscitation, which is tested using the Parkland formula. This formula is 4 milliliters of lactated Ringer's solution multiplied by the patient's weight in kilograms, multiplied by the TBSA percentage. The NCLEX will absolutely trick you on the administration timing. You must give the first half of the total calculated fluid volume over the first 8 hours and the second half over the next 16 hours. Here is the critical point many test takers miss. The clock for these first 8 hours starts from the time the burn injury occurred, not from the time the patient arrived at the hospital. If a patient was burned at noon and arrived at 2 p.m., you only have 6 hours left to administer that first half of the fluid. The exam will give you the patient's weight, the TBSA, and the time of injury, and then ask you to calculate the correct IV pump rate in milliliters per hour. Perhaps the most important priority in burn management is assessing for an inhalation injury, as this is an immediate threat to the airway. Always be suspicious of an inhalation injury if the burn occurred in an enclosed space or involves the face and neck. Clinical signs the NCLEX will give you are singed nasal hairs, a hoarse voice, soot in the mouth or sputum, and facial swelling. If you see these signs, your priority is airway management, which may mean preparing for early intubation before severe edema closes the airway completely. A question might ask you to choose the priority nursing action for a newly admitted burn patient, and if signs of inhalation injury are present, securing the airway always trumps fluid resuscitation or pain management. For a memorable shortcut, remember rule of nines, then fours, and always A. This stands for using the rule of nines for TBSA. Then the Parkland formula, which starts with the number 4, and always prioritizing airway first. This helps sequence your thinking under exam pressure. You must also differentiate burn depths. Superficial burns are red and painful, like a sunburn. Partial thickness burns will have blisters and be very painful. Full thickness burns will appear white, leathery, or charred, and surprisingly, they are often painless because the nerve endings have been destroyed. The NCLEX will test your understanding of these differences to gauge your knowledge of wound care and infection risk, which is highest with full-thickness burns. Infection prevention, including proper hand hygiene and sterile technique during dressing changes, is a major focus of long-term care.